So in this slide, we see the Johns Hopkins Nursing Evidence-Based Practice Appendix G Individual Evidence Summary Tool. I apologize that it's really small, but I just kind of wanted to get it all in one slide. The first I chose, well, actually I chose to just kind of discuss four articles. The first article was Berdot and al. et al. This was a systematic review and meta-analysis. So 5,312 records from electronic databases were searched and identified for this particular article. 7 studies were included, 5 were randomized controlled trials, including 1 crossover trial and 2 were non-randomized controlled trials. This article offered the ability to see the heterogeneity in studies performed using methods of electronic barcoding versus education and training to prevent medication errors. For this one, actually there was a limitation of the lack of blinding to the outcome because the observer was being aware to which the patient was allocated and the risk due to direct observation. So, I mean, they're talking about basically the Hawthorne effect. And you'll see that, I guess, with multiple studies, the main limitation was the fact that the observer knew that they were going to be observed. The evidence level and quality of this particular article was rather high, and it was a level 1 because it was a systematic review and it had an overall meta-analysis. For the second article, Bonwisky et al. This was basically an observational study. It was performed at an academic tertiary care medical center emergency room in University Hospital at a level 1 trauma center. It basically is a 70-bed ED that has an annual census of over 75,000 patients. A total of 1,978 medication administrations were observed. 996 were before barcoding and 982 were after barcoding. So the study findings, basically, they came up with the idea, or actually they noticed that by implementing barcode medication administration technology in the emergency room, there were significant reductions in medication administration error rates, and specifically with wrong dose errors. The results of this study suggested that there is an obvious benefit to barcoding on reducing medication administration errors in the ED. Again, with this one, as with any typical observational study, the Hawthorne effect was a known limitation. This level of evidence was a 4, and it was medium on quality. The next article was by Poon et al., and this was a before and after quasi-experimental study. They observed 14,041 medication administrations and reviewed 3,082 order transcriptions. Observers noted 776 non-timing errors in medication administration on units that did not use barcode electronic medication administration records. And there was a 41.4% relative reduction in errors. The rate of potential adverse drug events fell from 3.1 without the use of barcode technology to 1.6 with its use, so representing a 50.8% relative reduction. The rate of timing errors in medication administration fell by 27.3%, but the rate of potential adverse drug events associated with timing errors did not change significantly. Transcription errors occurred at the rate of 6.1% on units that did not use the barcode technology. And yeah, I mean, it basically stated that, there was some significant reduction in errors. as well as potential adverse drug events. So this particular study had listed several limitations. First, the results reflect the experience of one hospital that already has fully implemented computerized physician order entry for physicians and barcode verification for pharmacy staff. Hospitals that choose to implement the barcode technology without computerized order entry, physician order entry, and pharmacy barcode verification, or both, may find that it has a different effect on medication errors. Second, the study examined potential adverse drug events, not actual adverse drug events. Third, the study hospital designed the application in close collaboration with users and clinical leaders who were willing to support a substantial change in workflow to improve the overall medication process. And fourth, the nurses observed in this study might have performed better because they were being watched, as I mentioned, the Hawthorne effect. And fifth, even though the observations were made simultaneously on the units with barcode technology, the staggered rollout schedule meant that more observations were made on units without the barcode technology during the early part of the study. So that's kind of some of the limitations that this article noted. This level and quality was 4 and medium. And the last article is by Kabillion, Hughes, and Shannon. And this was a retrospective descriptive study using quantitative data of all medication errors reported through the hospital's electronic incident management system between January 2010 and December 2015. The study occurred in an emergency room, a major trauma facility that basically saw over 60,000 patients annually. The clinical areas within the emergency room basically consisted of a 5-bed resuscitation area, 25-bed acute area, ambulatory care, 10-bed ambulatory care, a procedural area, and a 14-bed short stay unit, kind of. So medication errors in the ED occurred at the busiest times during the busiest periods. Half of the errors in the ED involved high alert medications, which caused more harm compared to non-high alert medications. The findings indicated that errors in prescribing and administrations were common in the ED, as well as prescribing errors often triggered medication administration errors. So mainly knowledge-based factors led to prescribing errors and were related to incomplete patient assessments and underutilization of reference materials. Slips and lapses characterize medication administration errors. Slips could be attributed to the lack of adherence to the safety barriers such as the rights of medication administration and independent double checking. So the limitations are the prospective design and the lack of objective data on the root causes of errors or their antecedents. Additionally, reported errors might not have reflected the entirety of the errors that occurred in the department. This one was a level 5, and the quality actually was pretty high because they focused on the ED specifically and had a lot of good research implications noted on there, and talked about some possible solutions to look at when performing this study. So I thought it was pretty good.